begin this academic journey, it's my privilege to invite Dr. Sakti Prasad Das sir, member of Board of Director, DRIEMS University, who is a respected figure in our fraternity, known for his clinical excellence and academic contribution, to kindly come forward and introduce the esteemed guests and dignitaries gracing this occasion with their presence. Please, sir.
Good morning, respected Arun sir and all the faculties, Maulin, Nischal and Tejas and Principal Durga, my colleague Pavitra, and all the students of this university. This is really honor today. We are conducting this unique meeting, you can say, on the current concept of the brachial plexus injury in children. So this is a real issue uh, we come across. And today we have got the experts with us. Those as a team, they work. As all of you know, most of our students are physiotherapy, occupational therapists. So this is teamwork. A nerve surgery, a decision making, a surgery which involves a orthopedic surgeon, pediatric surgeon, and a splints therapist. A go so one day program today has been organized. So I am very much thankful that with a lot of pain, our colleagues they have come from Ahmedabad. I now please Dr. Maulin Shah, please stand. You should see the chief of the team, Dr. Maulin Shah. Dr. Maulin is a renowned pediatric orthopedic surgeon. Last 7 years, 8 years, he's taking the first prize in pediatric orthopedic surgery meeting. Any brachial plexus in last 5, 7 good publication is JBJS and Journal of Pediatric Orthopedics. Maulin has published all the papers in current concept of brachial plexus injury. Sir was telling me the group in while discussing Arun sir, you were telling Dr. Mukund Thatej there. I know they are also team member. They also work simultaneously. He is also a team member with them also. But this group is also good. You interact with them, you will know it. And Nischal, pediatric surgeon, plastic surgeon, most of the things. Nischal, please stand up. A warm welcome to Nischal. Tejas. Tejas is your friend. He will guide you in the post afternoon about the splint and therapeutic aspects. Everything he will teach you at the post lunch session. As you know, in the post lunch, we will have a group of therapists as well as a group of surgeons divided and other discussion. But in the morning session up to lunch, there will be a combined meeting regarding everything. I don't want to waste much of time. Now I request the team. Now, Maulin, you have to lead and you have to start your program as early as possible. Thank you very much. Sorry for the delay due to some of the minor problems. Thank you very much.
So want to get those lights off.
Hello, 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 hello.
So first priority should be it should be seen well here and not just the YouTube live, You ask them to make YouTube live, so they're focusing only on YouTube. children smiling throughout their childhood, you know, and we know that this is not a single person's journey. A child is born at obstetrician's place, and a pediatrician or neonatologist is invited to have a look at the child, and he sees that there is no movement in one of the limbs. And then sequentially, physiotherapist, occupational therapist, radio imaging, neurologists, plastic surgeons, and pediatric orthopedic surgeons, they all are involved at some period in time. And so the newborn parents, there's not only newborn child, but the newborn parents within brachial plexus birth palsy, they keep on shuffling from one place to the other. And what happens if the patient goes to a plastic surgeon, he discusses something different. A physiotherapist would talk in some different terms. They'll reach to a neurologist and he would talk about MRI and EMGs. And they reach to orthopedic surgeon, we talk about ultrasound, and they get confused. And I compare this scenario with this postman, the conventional postman who used to come at our flat, and we had 12 flats in one building, and we had such 36 flats. So that fellow will climb each flat up to the third floor, come back, deliver the post, and by the end of his journey, he would be absolutely tired, and I would offer him a cup of coffee. But now I have shifted to a new apartment where we have these post boxes at the bottom or the ground floor. And he finishes his job in about 15 minutes and he's fresh. And now he offers me a cup of coffee sometime. So this is the scenario we see. If a family keeps on moving from one place to the other, they get confused rather than they get a concrete composite opinion. And that's why we started what's termed as a comprehensive brachial plexus clinic in Ahmedabad since 2009. I returned from my fellowship training program in 2009, and we were inspired by a similar clinic run in Hospital for Sick Children, Toronto, wherein a team of consultants would meet on a specific day of a month, and patients were enrolled in the clinic and they asked to come on those days. And there we would sit in a room and we'll see the patients. These are young us in 2012. Dr. Nischal, our pediatric neurologist, young Dr. Tejas, and myself. And then we kept on shifting to the better premises and we conducted these clinics. All these patients from day one, they were enrolled into this clinic and a specific details enrolled in this proforma. And so we have the data of all these patients from day one till they reach the puberty and adulthood. This is a typical follow up. It's very important that we all should talk in same language. We cannot you cannot refer a child as, sir, this child is little bit moving the limb, or child was not moving the limb before, now it is moving. So little bit is not the term we should use. There should be a uniform examination tool. Like in cerebral palsy, now we talk about GMFCS, FMS, and so on, hemiplegic. So we should have a basic examination tool which we are going to teach you today, how to evaluate a child. And then we should talk, when you refer this case to an orthopedic surgeon, plastic surgeon, you should talk in that term so that we all are in the same page. So we need to teach you this evaluation, which is more important than the treatment. And we are so glad and proud that we have more than 1200 patients enrolled in this clinic over last 16 years, and probably there's the largest series in Asia. And we have kept our knowledge dispersed to different parts of not only India but abroad. We have been discussing, communicating, observing, researching, and we have around 40 papers published in different journals on brachial plexus birth palsy. And we really wanted to dissipate this knowledge first to the physiotherapists and occupational therapists, because they will be dealing with these children every day in, day out, and they must know how to evaluate what will be their recovery after nerve surgery and so on. So this meeting becomes very important. because we want to introduce this concept in Odisha, state of Odisha. We have been lengthy discussion with Dr. Shakti Das that how we can reinforce this education. And yes, we have done a lot of CMEs. You see all this youngsters are physiotherapists from Gujarat and different states of India. And today is the 20th such consecutive CME. And we also of late started conducting live surgical courses at our center, wherein we train the plastics and orthopedic surgeons. We demonstrate surgeries, and there they get an advanced knowledge, and we have a high quality discussion. We are trying to mimic Ganga people, here. I was talking to Dr. Rajshekharan back then, but we have also started that way. Now, what is structure of today's CME? There is no moderator. It's a self-governing CME, okay? And it's an interactive CME. So you do not feel shy to raise your hand, and we would like to interact, answer your questions if you have. Okay? And remember, a silly question will give you a good mark. Not hesitate in asking question. So the first session would be talking about how to evaluate a child coming to you with a brachial plexus birth palsy. Second session would be on treatment principles and protocols we follow. Post lunch, we will talk about treatment videos. As Dr. Shakti Prasad said, Shakti Das said that we will bifurcate, and we will, Dr. Tejas will talk to you about the physiotherapy protocols and aquatherapy protocols and so on. And we'll discuss surgical steps in our surgical team. And then again, we will show you some long-term outcomes or those pediatric patients now who are now adults and how they are behaving in their life and so on, and what are the keys to success. Let me start with the first session. I was talking to sir, and he said, I have seen only 4 patients in last 20 years. But the magnitude of problem is significant actually. The incidence is 1.2 to 3 per thousand live births, which is same as clubfoot incidence. But the education is that most of them improve spontaneously. That is not right. Only 70% of them improve spontaneously, and 30% need some or the other intervention. Our goal is to catch them in time. Otherwise, it will lead to lifelong disability. Incidence has not changed despite in the increased rate of C-section, because we cannot predict shoulder dystocia. And there are many countries, they have tried shoulder dystocia mock drills, but still the incidence has been the same. So, and of course, it leaves behind the infant with significant morbidity, and 30% have permanent weakness. We know that there are many risk factors, fetal and maternal. Shoulder dystocia, so you want to work on it? So shoulder dystocia is one of the most important risk factor, and there to predict whether this child would have shoulder dystocia is not easy, and that's why we end up seeing this many patients. A mother who has diabetes in pregnancy or a small stature, and there is prolonged second stage of labor, all this leads to higher chances of brachial plexus birth palsy. You know what first advice I give to this family when they come to my consulting room? I always advise you, go, if you are planning next pregnancy, you go for C-section and not the normal delivery. The reason behind is, in about 95% time, the second baby weighs more than the first baby. And this is because there is lesser autoimmune based apoptosis in that child. And increased body weight leads to increased shoulder width. And so the second baby would also have a chance of shoulder dystocia. Out of this 1200, we have 10 families where they have where they went for the normal delivery in the second baby, and the second baby also had birth palsy. So that's the first advice we give. C-section, yeah. So we have three patients uh, out of this 1200 who had brachial plexus birth palsy after C-section. These are the children who are stuck in the pelvis, and when they try to pull, sometimes their involvement is little different than what we see in this, but and they have a higher incidence of associated fractures because in the process of pulling them out, they have contralateral humerus fracture and so on. Another thing when this family comes to us, the first and foremost thing is we used to term it as an obstetric brachial plexus palsy, right? And OBPP was the terminology used for pretty long time, but we have stopped using that terminology because when you use term obstetric palsy, the doubt or the blame goes directly on your obstetric colleagues, which is not true. The incidence of brachial plexus birth palsy across the globe is same. So, and Indian obstetricians are more capable and trained because they are dealing with huge number of patients, And so we do not use the term OBPP. We use the term BPBI or brachial plexus birth palsy, brachial plexus birth injury. That's the first thing. After what time have you studied? Control, control, delete करना. Hmm. And now switch user से तो क्या होगा? हाँ, तू चिंता मत कर. Don't worry. Hmm? Don't get panicky. बड़े बड़े देशों में छोटी छोटी बातें होती रहती हैं. So let me see how many of you are physiotherapists and how many of you are occupational therapy students. Very good. And how many plastic colleagues we have besides sir? Plastic surgeons. Good. Orthopedic surgeons. Yeah. Yes, that's right. So you all will have going to have a very good time in the afternoon as well in the morning because I personally feel that the therapist should be trained well to evaluate the system updates and what's going on. Okay. So by the time this thing's working, we will keep on talking and you can interrupt me whenever. So what advice you will give when if let's see a child with a flaccid limb comes to you, what is the first advice you will give to the family? Or let me ask the other way. Should we apply a plaster or splint so that there is no further damage to the already injured nerves? How many of you think that we need to put them in some sort of splint or immobilization? Please raise your hands. Or first of all, let me ask, how many of you have seen children with a child with brachial plexus birth pulse? Yes. So a lot of you have seen and many of you have not seen also. So those who have seen, have you seen a newborn with brachial plexus palsy? Yes. So what do you think, Dr. Anil? Should we immobilize them in some form of splint or immobilization is not needed? And a newborn, yeah. Okay. So the first thing you said, we do not need to immobilize them. So whenever a child comes, of course, you need to get an X-ray to make sure that it is a real paralysis and not a pseudo paralysis. Because pseudo paralysis means if a child has sustained a clavicle fracture, or a humerus fracture in the process of a child is not going to move the limb. So you should not get it confused with the brachial plexus pulse. बात थोड़ी देर में हो जाएगा हाँ कोई okay. So next question is when a formal physiotherapy should be started in these children. Yes. When do you think we should refer this case to a physiotherapist? Say you have received a newborn, a pediatrician called you, you are an orthopedic surgeon, sir, we have this child of palsy. When will you refer them to physiotherapist? On day one? No. So what would you advise? Anil?
Sir, I would advise to do home-based therapy and wait for 3 months. Will advise them to look for the return of biceps function
Yeah.
by
So
3 months.
the key thing you said rightly is we need to teach them some passive exercises. We term it as a rule of five, which should be done by mom. They should spread the fingers. They should move the wrist, fix the elbow, do pronosupination, take the hand to mouth, and then take the hand to the occiput. So these are the five exercises to be done 5 times before every feed. So that is 5 times. So that is a rule of five. And then we continue this scenario for 1.5 months because till that time we do not want to expose the child to the external environment to get secondarily infected. So the role of physiotherapy starts after 1.5 months. Until that time, you do the home program.
Here we prescribe a you can say a sleeping board in which the limb will be like in shoulder in flex abduction, external rotation, elbow in extension, and also the hand in pronation. And this position which the child is sleeping, we prescribe a board for 6 weeks. What is your opinion?
Yeah,
Sometimes when he sleeps, otherwise therapy part is okay.
right. So again, like we see some children who already have external rotation abduction contracture since birth. These are the extended palsy. So, and at night time, we do not want them to make it extremely tight or so. So we do not prescribe any bracing unless they have some form of contracture, early contracture setting. If they do not have contracture, then we do not indulge into splinting earlier on. But yes, later on, they need some form of splinting. I think this shows the final steps of update and it will start in a moment. Okay, the next question is when will you suggest an investigation to confirm the diagnosis? So, how many of you think that an MRI is essential to confirm the diagnosis? And would you prescribe an MRI? Yeah.
In 3 months, the bicep tendon reflexor is
Hmm.
not present, then the MRI can be done to check.
By the 3 months, yeah. Yeah. The question is whether you would suggest MRI in first visit. The child is around a month. Yeah. So the answer is the mainly diagnosis is clinical. MRI we do in certain cases while we want to go for nerve surgery to see the extent of injury. And many a times there are fallacies in the report of MRI and what we find on operative field. But MRI can be done when you want to go for surgery. But to stamp the diagnosis, clinical examination is the key. Right. So हाँ, निकल जाओ। चार्जर को Yes, say all of that. Mm. 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 All of that. Mm. Oh, sure. Mm. Good. Good name. Email.
mm, mm,
So if this problem persists, then we'll bypass Google Meet. He is trying. Then the problem. Speed of internet seems less. Right. So can we start now? Okay. So we are back and sorry for this glitch. I think we were here and Right on. So, coming to the epidemiologic data of these patients, in international literature has been published that if a child would weight more than 4 kilograms, then there is a risk of brachial plexus birth palsy. But we followed our patients and we found the average body weight of Indian children was 3.48 kilograms. And so that means that the Indian mothers are tinier than Western world, and we should not rely on all Western data for Indian children. And we saw that our obstetricians are courageous enough to deliver this 5.5 kilo baby from a railway athlete, and the child had panplexopathy. Question is, why this brachial plexus palsy happens? Basically, this is an intrauterine position, the second phase of labor with the contractions. The baby propels down and the posterior shoulder gets stuck with the sacral promontory, and that leads to shoulder dystocia. In this case, the Mac Roberts maneuver is done where the mother's limbs are flexed and the fundal pressure is given in order to deliver the anterior shoulder. And in attempt to deliver the posterior shoulder, the nerves get stretched and that leads to nerve palsy. So the first encounter we talked about that we have to safeguard our OBGY colleagues because the incidence is same. We should use the term BPBI and not OBPP. The children with birth palsy have a tendency of looking away from the site of injury, and by doing so, they can develop secondary torticollis. And one can prevent torticollis by gently putting a pillow or something to prevent the neck from tilting and to prevent to have this secondary deformity. Parental counseling is very important. And if a child is showing panplexopathy or signs of root avulsion, we introduce surgeries from this go, that your child might need surgical intervention. And as I mentioned already, we must differentiate a paralysis from pseudoparalysis. We see lots of children with clavicle fracture, humerus fracture, and in our data, around 930 patients, there are 4% patients have demonstrated these fractures, wherein clavicle fracture was most common. But this fracture does not safeguard the plexus. About 9% of these patients required nerve surgery, and about 57% patients require shoulder rebalancing in this case. So that was a thinking that when a bone is fractured, the force on the clavicle, on the plexus is lesser, but that's not true. Even with a patient with a fracture, they might need some surgical intervention. And sometimes you are exposed to this sort of injury wherein there is a shoulder, it is referred as a shoulder dislocation, but when you get an MRI, you will find that this is not a dislocation, but this was a physial separation, and this needs to be treated conservatively. We could publish this report in JBJS. The next step is to further evaluate these children, and clinically classify what sort of injury they have and to see the early signs of root avulsion. And then we will talk about how to evaluate older children. So I would invite Dr. Nischal Naik to talk about the clinical classification of injury. Any questions so far? By the time Dr. Nischal comes on the dais, we can discuss that. Now, these all are secondary to the birth injury. We have a few patients who have traumatic birth palsy, but these patients are all post-birth injuries. There are very few post-traumatic.
So these are due to deficiency in the obstetrician's maneuver, or it is due to a natural way of having
So
this?
that's what people used to think, that that is deficiency, but the, we don't talk that way. The shoulder dystocia cannot be predicted. So that's a very the duration of that event is so short that many a times obstetricians cannot put their forceps or their maneuver to disengage that shoulder, because they are also fearing of hypoxia. So their goal is to deliver the baby as quickly as possible, and the incidence all across the globe has been the same. So, and as I have always felt that our obstetricians are really well trained, because they have been delivering lots of cases. Maybe there are certain areas where the deliveries are done by the trained nurses or guys, and the obstetricians are not available. There are some pockets in Gujarat. We see a lot of referrals, and we have mobilized that this center should have trained obstetricians. But otherwise, we see the similar number of patients from urban area also. So we do not attribute this to obstetricians' mistake, because they unnecessarily they can get into trouble.
But in periphery like Orissa, most in the rural places, the Anganwadi or the even trained nurses, they do most of the normal deliveries.
Yeah, that is
So,
right.
so there is a gray area. We don't know how it happens.
Yeah.
So nobody has ventured to see actually what is the cause. Either it
What I
was,
also have seen, there are certain geographical areas where they think that baby should be delivered through normal delivery only. If you suggest a C-section, then they think that they want to do C-section because they want to earn money, doctors. And then they, even though the child has signs of shoulder dystocia, risk of dystocia, baby weight is high, they still pressurize the doctor to get normal delivery. So those are the also cases
yeah.
where this can happen.
Thank you.
Yeah.
Morning, sir.
Good morning.
Sir, keeping aside the development of an infection secondarily, is physiotherapy an absolute contraindication to be referred to before 1.5 months for a neonate?
No. Only thing is, the newborn has certain degree of pain at that time, and a gentle passive range of motion exercise is what is needed, which can be very easily done by parents, you know. And of course, they need to visit monthly. So if we see the signs of early root avulsion, as Dr. Nischal would tell you, then we need to prepare the family that this child has a possibility to need an early nerve surgery. So an interaction of doctor and patient is needed for that, because if you come to me at 6 months, I'd say you will need surgery. It's a process to build that family for that major encounter of their life. That's one. And as this exercise can be done by parents, we do not want to expose them to multiple doctors, you know. And of course, if they need some sprint, yes, they just want some.
Press, other than doing the gentle passive range of the motion, some tactile orientation, we don't have much role in first 2 years of, first
Two
2 months of
months.
their life. Because we cannot give the electrical stimulation in first 2 months of life because it will hamper the Valerian degeneration.
Yeah.
So that this exercise can be done very easily by the parents. And that's why we don't insist child to come daily on the daily basis for the therapy.
The electrical stimulation should not be started in first 2 months. That's the message.
Good morning. Uh, am I loud enough? मेरे को ये दिखना भी चाहिए. So we'll be discussing injury types, clinical and morphological classifications of brachial plexus birth palsies. Now, basic anatomy, it's broadly divided into roots C5, C6, C7, C8, and T1. Five roots, they form brachial plexus. Then they form upper, middle, and lower trunk. And then they are divided into anterior and posterior divisions, from which the cords, medial, lateral, and posterior cords, they are formed. And then they give branches. Now, we'll talk about the significant or important, clinically important branches from upper trunk. Suprascapular nerve is very important. It gives supply to supra and infraspinatus muscles and very important for shoulder abduction and external rotation. And you will see that more often this is the movement that needs to be rectified surgically in most of the cases. From the lateral cord, musculocutaneous nerve and lateral part of median nerve, which is more often sensory. These are more important. Lateral pectoral, which supplies the pectoral, is major muscle. That's also important. From the posterior cord, thoracodorsal nerve, it's very important because it supplies lat dorsi and teres major muscles. And if this nerve is not functioning, you will see that a lot of shoulder surgeries cannot be done. Radial nerve, which is important for elbow extension, wrist extension. And yes, I forgot the axillary nerve, which is supplying the deltoid muscle, which is very important. From the medial cord, there are two cutaneous nerves of forearm and arm. And apart from that, very important nerves which control the hand, medial nerve and ulnar nerve. That is very important. Ulnar nerve is for intrinsic functions, and median nerve is more for gross functions and thumb movements. So, categorizing it into myotomes broadly, C5 is for shoulder abduction and external rotation, C6 is for elbow flexion, C7 is for elbow extension and wrist extension, C8 is for long muscles of forearm, that is for grip or shaking hands, and T1 is for the small muscles of hand or say interossei, lumbricals, and other small muscles. Now, clinically, obstetric palsy or the birth palsy is divided into four types. That was described by Narakas. Narakas 1, that is C5 and C6. Roots are involved. Can somebody tell me what would be the clinical loss of movement in type 1 Narakas injury? Can someone tell, please?